you know, at the hospital. And then we do have a second webinar that starts from 2 o'clock, which you can still register for if you'd like. And the second one will be on emotional impact lymphoma, aggressive lymphoma, and CAR T cell therapy. So please register if you want to join that one as well. We have quite a few people online today. We have over 300 registrations, which is wonderful, and it just shows the need that we do have for education and our role of trying to get that information out to you. So thank you for joining us today. And we do have people registered from right across Australia. Every state and territory is represented today. And we also do have a couple of registrations from New Zealand, UK and the US. So welcome as well. So we are currently planning more of these events, and so we'd like to hear from you what you'd like to hear, even a bit more specific information things, so just let us know, okay, for any future events. So just a little bit of housekeeping. Obviously, you're all going to be on mute, and the reason being we can't have 200 people talking over the top of each other and talking at once, but I do have a few questions that some of you have emailed through, and thank you for that. But if you do like to ask a question, which we'll be waiting till the end, there is a Q&A icon at the bottom of the page that you'll see, and you can put your questions in there, and we'll be monitoring that for the end, and I'm sure Mike will be able to answer that for us. So otherwise, this will be recorded as well, and we'll be posting this and uploading this probably by tomorrow, but we'll send those out to all the links that you found out about today's event as well. So just a little bit of an introduction about myself. Firstly, I'm the National Nurse Director with Lymphoma Australia, which I mentioned before, and I'm based in Melbourne, although I do hold a national remit. I do have over 25 years of experience in haematology nursing, and particularly in lymphoma. And a lot of my role involves managing the lymphoma care nurses across Australia, and I'll introduce a little bit about them soon, and leading Lymphoma Australia and some quality initiatives across the country, providing advocacy, awareness, education and support for patients, carers and healthcare professionals. So my role is quite varied, but you'll probably see me at some point in the future around the country. So we're very fortunate today to have our first presenter, Dr. Michael Gilbertson from Monash Health here in Melbourne. But firstly, I'll just quickly do a bit of an update on Lymphoma Australia and some of the supports that we might be able to help you with, and ways that we can help health professionals as well. We do have a few health professionals online today too, so that's great. Thank you. So as I mentioned, we're going to be having Michael coming up shortly, and he'll be giving us a really great presentation on some of the novel therapies and new therapies in the indolent, slow-growing lymphomas, and we can ask questions afterwards. I'll introduce Michael a bit better in a second. But firstly, just want to go through a little bit about what Lymphoma Australia does, and we are an incorporated charity and dedicated to lymphoma, and the only dedicated charity in Australia that's dedicated to lymphoma and CLL. We have lymphoma care nurses, and we also have a medical advisory committee who work alongside us to ensure that a lot of our content, our website and our fact sheets and resources are all up to date and the latest information, and also have our clinical support. We provide a lot of awareness by attending lots of national conferences and meetings and whatnot across the country, and also internationally as well, to ensure that we bring the best information to you as well, and advocating on your behalf. We provide support through our online phone and through our lymphoma care nurses. We advocate for new medications that are coming through on the PBS, and we fight on your behalf as well, providing submissions for the best treatments. We collaborate with other organisations across the country, including the Lymphoma Coalition, which is the international lymphoma patient advocacy body, that we work with them to ensure that we're providing the best information for you, providing education events like today. We provide resources which you can get on our website. And if you aren't already hooked up, we can sign you up to our newsletter as well. So keeping you up to date and letting you know about events such as this as well. So please let us know if there's anything else that you need us to help you with. We're very open to new ideas. Just a little bit about who we represent. There's nearly 6,500 people across Australia who are diagnosed with lymphoma and CLL every year. And it's the sixth most common cancer in adult men and women, the third most common in paediatric and children up to the age of 14, and it's the most common in the 15 to 29-year-old age group. So we obviously represent all ages and all these 80 different subtypes and over 80 different subtypes, but some of these are very rare. So we're a voice for that crowd of people, and the numbers are doubling, and we're helping to support and change them with as research comes about. This gets really confusing. Just to remind people that, you know, there are many, many different types of lymphoma, and all lymphomas do have different characteristics and different ways of being treated. So it can get quite confusing when you hear you've got lymphoma and listening to other patients' stories. It is completely different, and we really recognise that and making sure that you have the information that suits you the best. Our role does take us across the country, because we know that patients are dispersed across the country through metropolitan and regional and rural areas, and we're trying to get out to those more regional and rural areas a bit more, because we know that not everyone's referred to a large metropolitan specialist cancer centre, and a lot of patients are being treated in the smaller cancer centres regionally, and private practice. So we're ensuring that we try and provide equity of expert advice, education support, regardless of where you live across Australia. And I think today is quite tribute to that, trying to be able to get out to everyone across, no matter where you live. And not everyone we know is actually have access to the best treatments or offered a clinical trial. So at least we try and keep you informed of where you can get that if you like and know it's an option. For those who haven't seen, our resources are available online. You can also order some hard copy booklets as well through our website, and our fact sheets can be downloaded and printed free off our website. And we've got multiple different topics and different subtypes: supportive care, management of lymphoma, and we're continually adding to these over time as well. And eventually we'd hope to cover most subtypes, which is a bit of a mammoth task. Our newsletters, we keep everyone up to date with what's going on around the lymphoma world. So please link into those so we can keep you up to date. And also we have the YouTube video library as well, which is something we've really been working on over the last 12 months. And we have a lot of short videos and like presentations such as today we'll have on our YouTube channel as well, so you can watch at any point in time and keeping you up to date. Our lymphoma nurse support line is a line that anyone can call, patients, carers or health professionals, and it's free by calling 1800 953 081 from anywhere across Australia. Or if you'd prefer to email us on nurse@lymphoma.org.au, we can actually email you back and send you resources through online. But the service is only Monday to Friday through business hours. We're not an emergency line, or if you have any medical advice you're needing some assistance with, it's best to call your medical team, because we are just more of a support and advice line. So again, we're going to be providing a lot more of these education events as we go over time, and we do often have international guest speakers that we arrange presentations with, local speakers such as today, and we do record a lot of these events as well. We also have a lot of expert interviews, and so you may have recently seen that we went to ASH in the US, and we brought back a lot of expert interviews from over the conference to keep you up to date on the latest information and research. Those who aren't involved in the Lymphoma Down Under support group, I encourage you to join, and it's a great online supportive group for patients and carers and of lymphoma, and you can join through the Facebook group, and it's a great supportive platform. We also have all the usual social media, Twitter and Instagram and other YouTube videos. And we do have local support groups, but we are putting those online shortly as well. We're just trying to work out the right platform. And for those healthcare professionals who are online at the moment, we do have a lymphoma nurse special interest group, which the lymphoma care nurses lead. We have over about 1,300 members across Australia and also overseas as well. All healthcare professionals are welcome. And we also have a private Facebook group for them as well, Lymphoma Nurses Down Under. And here we provide a weekly newsletter of all the updates and publications, videos, podcasts, whatever comes through once a week, and a quarterly newsletter and all the education events, PBS updates, FAQ updates, things like that. And of course, we let you know about education events. So please hook up if you're a healthcare professional. And just finally, we just a few upcoming projects and things to keep in the back of your mind is that we do have a new website that we're putting together at the moment. We're busily writing for that. And so that will be launched probably next few months. So we'll let you know once that's done. And we're very exciting, some of the information we're putting in there, and we're open to any requests and things that you'd like to see there too. New resources have been released at all points time, including we've got some COVID-19 and other indolent lymphoma fact sheets for different subtypes on there. We'll be doing some more education webinars and more expert interviews from updates on the major conferences across the world. We also have some nurse learning modules we're starting to plan for as well. So I'll keep you updated. And of course, we have our lymphoma care nurses. And a couple have started. Unfortunately, this time we're all locked down, but we will be getting back out to the hospitals so you can meet them sometime soon. So thank you. And without further ado, we've got, I'll be introducing Michael to do the main presentation of the session. So we have Dr. Michael Gilbertson. He's a haematologist with the Haematology Service at Monash Health in Melbourne. Dr. Gilbertson has a particular interest in Hodgkin and non-Hodgkin lymphoma, where he has been the primary chief investigator on a number of clinical trials on lymphoma at Monash Health and international joint projects. He has authored and co-authored a number of peer-reviewed publications internationally. He's a member of a number of committees, including the Australian Leukemia and Lymphoma Group, ALG, which is the Australian and New Zealand's only not-for-profit blood cancer clinical trial research group, which the big meetings are on this week. So hence we've made this meeting today. Yes, I would like to welcome Michael, if I can unshare this page. Ooh.
Thanks very much, Donna, and thanks for the opportunity to talk today. So I'll just try and share my screen now. And hopefully that's come through okay. So I've been asked to talk today about novel approaches for indolent lymphomas, and it wasn't until I actually started to prepare this talk that I realised that there's actually a lot that gets spoken about at conferences and meetings and things, but not a lot put out in publication format, and I think that makes it quite difficult for patients and their families and carers to really try and keep abreast of exactly a lot of the developments and things that are going on. So what I thought that I would discuss today was firstly, how do we define an indolent lymphoma? And then move on and talk about firstly what are some of the standard treatment approaches that we have for these types of lymphomas, and then touching on some of the newer approaches both towards chemotherapy and other antibodies and small molecule inhibitors, a little bit about CAR T-cell therapies and other immune boosting type of approaches, and then talk somewhat around prognostic markers and how research in that field may impact on our ability to treat patients and to pick different therapies for patients. So the current classification of hematological diseases was published in 2016, and as Donna alluded to with the preamble about Lymphoma Australia, we know that there are over 80 different types of lymphoma, and some of them we characteristically define as being indolent diseases, and so some of the more common versions of that would be follicular lymphoma, marginal zone lymphomas, or MALT lymphomas, but really the main stay of therapy for these indolent lymphomas is around B-cell lymphomas. So that's where I'll be spending most of my time discussing things today. But certainly there are a lot of other indolent diseases, particularly some T-cell diseases. And then there are some diseases that can really straddle between being aggressive at times or indolent at times, even within the one patient. So the WHO classification very clearly tells us that in the course of the normal B cell development, going from bone marrow and then maturing through the through the lymph node architecture, and then finally being cells that can produce antibodies and to keep us well, protect against various infections and things. We know that at various points, abnormalities can develop in the cells, and that gives rise to the various B cell hematological malignancies. So, for instance, follicular lymphoma has a very characteristic set of mutations for most patients. And why that's important is that it not only defines the disease, but may give us something that we can target with some specific therapies and things down the track. And pretty much most of our lymphomas have got stuff that we can use in this fashion. Now, that's fine to have those genetic markers and things, but what we often rely on is just looking down the microscope. So this is a continuum of what the pathologist sees when they look down the microscope from a lymph node biopsy for patients with follicular lymphoma. So starting on the left, grade 1, or the most indolent or slow-growing type of follicular lymphoma, has predominantly these smaller cells and very few of these larger cells called centroblasts. As the lymphomas start to become a bit more aggressive, you start to see a few more of the larger cells and less of the centrocytes, the smaller cells. And then at grade 3A, this is the kind of upper level of follicular lymphoma, we predominantly see the larger cells with very, very few of the smaller cells. And it really exists on a continuum between that and then diffuse large B-cell lymphoma, where we see sheets of these cells. Now, this is all around classification and how we define patients via their pathology, but it actually doesn't make that much of a difference from how we would clinically manage a patient. We don't differentiate between grade 1 and grade 3A, for instance, in the types of treatments that we would give to patients. Diffuse large B-cell lymphoma obviously is an aggressive type of B-cell lymphoma and has quite different clinical characteristics to follicular lymphoma. But as you can see, looking down the microscope, there's actually a lot of similarities between them. Even within diseases, they can develop certain mutations that can make them either aggressive or indolent. So mantle cell lymphoma can really look like anything down the microscope and can certainly behave in very different fashions. So when we understand the underlying biology, we note that the main numbers of patients with mantle cell lymphoma will be in this category here, where they'll have specific mutations of some of the markers on the cells, and we can use that to find these patients and to pick the therapies. But this group here that have mantle cell lymphoma cells floating in the peripheral blood, they can look a lot like CLL, and up until this identification of this mutation of SOX11 being negative in this subgroup of patients, we didn't really know how to treat these patients or to differentiate them from the standard mantle cell lymphoma group. And so they were getting full dose chemotherapy and sometimes even stem cell transplants, when in fact these patients have a very benign or indolent type of disease and may never need any treatment at all, which has been discovered in the last few years. So when we're actually trying to think about treating patients, then we need to try and understand some of the pathways and things that are involved in the cell. And I'm sorry, this is a very difficult to understand slide with lots of cellular pathways and things included. But we'll step through each of these areas where we have therapeutic agents at the moment and where things might be heading in the future. So firstly, on the cell surface, the commonly expressed surface marker of CD20 is present on most B-cell malignancies. And that's important because we have a drug called rituximab and more recently obinutuzumab, the tweaked up version of rituximab, that is really very active in B-cell malignancies. And these drugs have really revolutionized the treatment of B-cell malignancies since rituximab came out about 20 years or so ago. So these antibodies basically bind to the surface of the cells via whatever cell surface receptor they're targeting, and then can trigger off the host's immune system or patient's immune system to then come along and kill off the cells. The next group of drugs are really trying to utilize the underlying machinery and the underlying mutations within the cell to be able to then kill off the cell from internally. So in this group of drugs, we see things like ibrutinib or idelalisib, or more recently venetoclax, that are acting to restore some of the mutations that are present in these cells that develop in the lymphomas, and then to basically give the cells the ability to kill themselves off, which is really the mainstay of cells being cancerous or non-cancerous. Most cancerous cells have lost the ability to be able to kill themselves off. The other way that cancerous cells, and particularly some types of lymphoma, can avoid the immune system is by basically hiding by changing the markers on the cell surface. And we'll talk about some of the checkpoint inhibitor therapies and how we can restore this balance so that, again, the patient's immune system can then recognize the lymphoma cells and be able to kill them off. So in approaching treatment today, I decided I'd really focus on follicular lymphoma. A, because it's the most common type of indolent lymphoma, but B, because of the fact that it's the more common type, then there's more clinical trials and things to be able to talk about it. But a lot of these principles can really be extrapolated to most of the other types of indolent lymphoma. So for follicular lymphoma, we differentiate between early stage, being stage 1 or stage 2, and advanced stage disease, being stage 3 or stage 4. Most patients in Australia these days would be staged with a PET scan, but some patients may still just be staged with a CT scan, and some patients will require a bone marrow biopsy to confirm whether they're early stage or advanced stage disease. When I have a patient in front of me that I'm considering treatment, I'm always trying to think about whether they'll be able to handle the treatment that I'm proposing, and that really takes into consideration all of those factors around the patient's age, their underlying comorbid medical conditions, and their general fitness and things for therapy. So for follicular lymphoma, a lot of people have historically thought of it as generally being incurable. Now, that in the strict sense of the word may be correct, but there's a lot of people who will actually get functional cure from just one round of treatment with the highly potent antibodies and things that we're using these days. So I don't think that we should think of this as really being a completely incurable condition. It's well and truly a controllable condition for very many patients. So there'll be some patients where we are really going aggressively to try and get as deep a response as possible. But then there are other patients with indolent lymphomas where we might just be trying to knock the edge off their symptoms and things. It's also very important to not be too aggressive with indolent lymphomas, recognizing that we can actually cause more trouble if we really go aggressively in patients that aren't able to be able to handle the intensity of the treatment. So I developed this slide many years ago, really to describe how we approach treating follicular lymphoma, and that really is the archetype for a lot of other lymphomas. And it really truly is a pinch of this, a dash of that. You can find people at various haematology multidisciplinary team meetings that can manage to justify a large number of approaches to be able to treat patients. So at one end, with indolent lymphomas, many patients, in fact, a third of patients, will not need any treatment at all, so-called watch and wait or an observational approach. And then there'll be other patients for which radiotherapy on its own may be enough, or more recently, radiotherapy plus chemotherapy is offered the possibility of curative approach. And then we move on to more traditional chemotherapy, antibody therapies, and bone marrow transplants and things. So for limited stage follicular lymphoma, and certainly this has been extrapolated to a number of patients with other types of indolent lymphomas, if they've just got a single site of disease, then we may just administer a short course of radiotherapy and hope that they're cured with that approach. Or more recently, the Australian and New Zealand Radiation Oncology Group published their findings that identified that patients with limited stage follicular lymphoma could be treated very effectively with a combination of both radiotherapy first and then subsequent chemotherapy. And that's highlighted in this clinical trial here, where about 150 patients received radiotherapy initially, and then either chemotherapy or no chemotherapy. And you can see in the survival curve over here, basically the patients who had the chemotherapy as well as radiotherapy did a bit better in terms of progression-free survival, to the point where at 10 years, still 50 to 60% of these patients have had no evidence of recurrence of their lymphoma, which is an excellent outcome. And certainly at that point, you'd be wondering whether they're truly cured at that point. So then in advanced stage follicular lymphoma, there's a question around whether the patient is truly symptomatic or not. And to define that, the French lymphoma study group, so similar to our ALLG, the Gila or Lisa, developed these criteria called the GELF criteria. And basically you need to have a lump that's causing you trouble, either according to the size or the number of the lumps, or if the lymphoma is causing other symptoms for them. And that's how we basically define that it's time to get on and start treating these patients. So standard treatment for follicular lymphoma in Australia would be with, once we decide that they're needing treatment, would be to go with predominantly these days an obinutuzumab, so Gazyva based antibody treatment in combination with either CHOP or bendamustine or possibly CVP. As I said before, though, a number of these patients can be managed just with observation alone. So this question around observation or treating earlier has been addressed in a few clinical trials over the years. And basically, the main thing to focus on here is this graph over here, where essentially there's no difference in survival between if you treat a patient earlier rather than if you wait until they develop symptoms. And that really informed us and gave us the confidence to say that unless the lymphoma is truly causing you symptoms or trouble at the moment, then you can wait until the patient truly needs treatment to then get on and start your treatment, and you're not doing any disservice with that approach. So the standard type of therapy that most patients are getting at the moment for follicular lymphoma in Australia was published recently, and in this study patients had either CHOP or bendamustine predominantly, and had either rituximab, so that was the old CD20 antibody, or obinutuzumab, the more recent tweaked up antibody. And what this study showed that was that independent of the chemotherapy backbone, was that patients with obinutuzumab compared to rituximab had an improved progression-free survival. And that has led most of us to change our treatment approach to using obinutuzumab rather than rituximab. There are some concerns with this approach in that when you increase the intensity of any treatment, and certainly obinutuzumab does that a little bit over rituximab, it does increase the risk of infections a bit. And that was one of the problems that came out in this clinical trial, was that patients who had obinutuzumab had a slightly higher rate of clinically significant infections compared to patients who had rituximab. In treating patients on that clinical trial, they had an initial 6 months of treatment, and then they had another 2 years of just the antibody treatment after the chemotherapy had finished. And we found that a lot of patients actually developed the side effects in terms of infections during the maintenance period, so after that initial 6 months of therapy. So it just because patients get through that initial 6 months, they're not completely out of the woods in terms of the infectious risk. And certainly recently with the coronavirus pandemic, that's really made us think about whether we should be giving maintenance therapy to all of our patients at the moment. That has is trying to be examined in a prospective clinical trial that the ALLG is participating in combination with the UK Lymphoma Study Group, and that study is called the Patria study. So I've explained for follicular lymphoma kind of the initial treatment, but we recognize that follicular lymphoma, like other types of indolent lymphomas, in many patients, they'll develop symptoms over time. They'll get diagnosed, have their first treatment, have an excellent response to therapy for the vast majority of patients. And then after a period of time, the lymphoma will relapse and we'll need to treat them again, and similar, so on and so forth. There's this kind of pattern. And so some approaches where we would basically treat patients for a period of time and at relapse or progression, and basically get a similar degree of control over the lymphoma compared to the initial treatment. But some treatments that we give nowadays, particularly with small molecule inhibitors, we're tending to give the treatment on a continuous basis and trying to keep the lymphoma under control for as long as possible. So at the time of disease progression, how do we manage patients? We essentially would biopsy them to confirm exactly what they had, work out via the same criteria that we applied at the start as to whether they truly needed treatment. We'd think about whether there was a possibility of allogeneic transplant, and then think about whether they needed autologous transplant. We would give them some second-line chemotherapy, and again monitor them after that period of time. And so most of what I'll talk about now is actually going to be around relapse disease, because that's where most of the research and things is being done at the moment. So for follicular lymphoma, this is just a selection of some of the stuff that's available for relapsed disease specifically. And I've blacked out some of the stuff that's not available in Australia at the moment, but you can see that there's a whole range of different things that have been tried in the relapse setting, both from standard chemotherapy with different antibodies and some of the more targeted therapies that have come to clinical trials, and many of these are actually available for use in on the PBS at the moment for this indication. So when we talk about small molecules in indolent lymphomas, just trying to illustrate how they differ towards bigger antibodies and things. So our standard antibodies, such as obinutuzumab or rituximab, are targeting CD20 on the cell surface and then initiating the cell death process that way. When we focus on some of these agents, such as idelalisib, we know that there's various cell machinery within the B cells, going from the cell surface essentially down to the nucleus of the cell. And normally that signaling pathway is conveying messages around the need to produce things such as antibodies or driving cell division or other various cellular functions. And we know that they develop mutations in various types of lymphoma. And so these agents are basically trying to come in and to block that pathway and stop that from working. Venetoclax, on the other hand, has been very successful for CLL or chronic lymphocytic leukemia, but hasn't had as much of a role for other types of lymphoma at the moment. That's acting in a different part of the cell and basically trying to restore the cell's ability to be able to kill itself off when it detects that there's certain abnormalities have developed in the cells, or that the cell has essentially passed its use by date and in the process of aging and needs to die off. So idelalisib is a PI3 kinase inhibitor. So PI3 kinase is in the B cell receptor signaling pathway, in the same pathway as where ibrutinib, zanubrutinib, and duvelisib and other agents that you may have heard of are all working. So in this clinical trial, patients had a number of lines of therapy before being eligible for this clinical trial. And what to take away from this is that basically about 50% of patients actually responded very well. And this clinical trial was updated recently. And in fact, in patients who responded well and achieved a complete response, then that response has essentially been maintained even out beyond 4 to 5 years. So in patients where it works, it seems to work very well. I'm not deceiving you in that idelalisib's got its own set of problems, in that a lot of patients needed to stop treatment because of adverse effects. And having treated a number of patients with idelalisib, I'd say that probably about 50% of patients will respond well with minimal side effects, and in the other 50%, we often work out fairly quickly that that the idelalisib has got some problems for them. And we stop the therapy, and usually their side effects all disappear. And it's an unfortunate situation because the idelalisib, I think, if in patients who respond well, it seems to work very well with long-lasting remissions for many patients. So changing gears somewhat to talk about the kind of sexy topic in hematological malignancies is around CAR T cell therapy. Now, I'm not a CAR T cell treating hematologist, so my understanding of the biology is not as extensive as Dr. Dickinson, who you're going to hear from later on in the day, but certainly my understanding of how these things work is that basically you take the patient's T cells and then process them in the laboratory, and that process can take up to 8 weeks or so to be able to generate a product. And basically you're retraining the patient's immune system by the injection of various modifications to then be able to recognize the specific abnormality within the patient. And with this case, it's been labeled as the tumor cell in this cartoon. And once these T cells are infused into the patient, then they can go around and basically recognize the tumor cell and then initiate the patient's immune system to then kill off the lymphoma or tumor cells. So it's a very exciting way of basically being able to use what the patient's already got and try and augment that response to kill off the lymphoma cells. So unlike aggressive B-cell lymphomas and acute lymphoblastic leukemia, there's not been that much published on the use of CAR T-cell therapies for indolent lymphomas such as follicular lymphoma. And this was presented at Lugano and at ASH last year on a very small series of only 8 patients with follicular lymphoma. But you can see that in these 8 patients, very few of them relapsed. Only 1 out of the 8 patients relapsed up to 3 years after the CAR T-cell infusion. So it would appear to be a very effective treatment in this small subgroup of patients. Sometimes follicular lymphoma can turn more aggressive and become basically diffuse large B-cell lymphoma, and that can be a very difficult situation to treat. And so they gave some of these patients CAR T-cell therapy, and again, the responses are not too bad compared to other patients that we know from historical experience with transformed follicular lymphoma often have a tough time and don't respond amazingly well to standard treatment. So certainly some further work needs to be done in terms of understanding exactly which patients with relapsed follicular lymphoma may need this therapy, but it's certainly a promising option. So whilst CAR T cells need to be manufactured for a specific patient and are potentially quite expensive from that point of view, and there's a time delay between getting the cells out of the patient and then being able to reinfuse the CAR T cell product. BITE cells or dual B tumor and T cell initiating agents tries to basically have an antibody that you can take off the shelf, much like we would take a vial of rituximab or obinutuzumab off the shelf, and be able to give it to a patient and hopefully be able to bring the host's or patient's immune system into play and being able to control the lymphoma. So a BITE cell basically takes part of the antibody that we know is going to engage with the immune system, in this case the T cells, and links it with a particular protein to something that is going to recognize the patient's tumor cell. So recently, Roche are in the process of completing a clinical trial with an antibody called mosunetuzumab, and in this antibody, you've basically got a bit of antibody that recognizes the T cells and aims to basically hold on to that with a linker in between, and then something targeting CD20. So Roche, with their background with rituximab and obinutuzumab, were pretty easily able to develop this CD20 component, joined it to a CD3, and basically gave it as an infusion. And the hope is that the T cell is then lying very close to the B cell, and then through that process can then initiate death of the B cell, which is indicated below here, through a series of cell signaling mechanisms. So it's a very interesting approach to treatment, and certainly something that doesn't need to be personalized for an individual patient, and may offer the ability to be able to give quicker, more specific therapy for a patient. So this was presented at ASH last year, and you can see in patients who had indolent lymphoma, and predominantly this was follicular lymphoma, the vast majority of patients responded, which was excellent. And based on this clinical trial, over half of or almost half of these patients had a complete response to therapy, which is really an excellent response based on the number of lines of therapy that these patients had had. So another way that we can tweak the immune system to be able to attack the lymphoma cells in follicular lymphoma and other indolent lymphomas is by understanding the biology of the way that the T cells interact with the tumor cells or lymphoma cells. So normally T cells come along and signal to the tumor cell that basically if it recognizes it as not being itself, it initiates a series of cell signaling processes and then tells the cell to die off. And tumor cells are unique in the fact that they produce this antibody called antigen, sorry, that called PD-L1 that basically blocks this receptor on the T cell, and that sends the message to the T cell that there's no trouble here. Don't worry about us. We're just normal parts of your body, and that's not what you want when you want an immune system to be able to recognize what's normal and what's not normal, and to be able to attack the stuff that's not recognized as normal. And so what these antibodies do is that you've got either an antibody that binds to the T cell and basically re-energizes the T cell, or alternatively you've got an antibody that binds to the tumor cell and stops that from turning the patient's T cells off and blocking that signal. So it's a way of essentially re-energizing the patient's own immune system, and then relying on the immune system to then be able to kill off the lymphoma or the tumor cells. And we've seen this approach being employed very successfully in some types of lymphomas, particularly with Hodgkin lymphoma. But more recently, it's been employed in into B-cell lymphoma. So this is a clinical trial that is very close to completing recruitment, being run out of the Austin Hospital here in Melbourne by Eliza Hawkes, and we've got it running at a few other sites around Victoria, where patients are given nivolumab. So this is an anti-PD-1 inhibitor. So basically, it binds to the T cells and re-energizes the T cells. And in these patients with newly diagnosed follicular lymphoma, we're not even giving them any rituximab or chemotherapy to start with. We're just giving them this antibody to re-energize the immune system, and then performing a PET scan after 4 doses of that to see the response. And we've seen and have presented at a couple of conferences that basically about 80 to 90% of patients at this time point, just with this immune restoration type approach, have had an excellent response to therapy. And so they've just been able to go on and just receive that treatment on its own. In patients where we haven't been as happy with the result, we've added rituximab, and the vast majority of these patients have then responded very well to treatment and have just continued on with both rituximab and nivolumab. So certainly an interesting approach, basically trying to utilize the patient's own immune system to be able to control the lymphoma. So what about different ways to try and augment that response? So this is a clinical trial that has been started up again by Eliza Hawkes with a similar rationale. But the reason why we would add radiotherapy to an antibody targeting the PD-1 pathway is really that historically, if you gave radiotherapy to someone with lymphoma, it was noted that sometimes if you irradiated one spot, you actually got improvement in other areas of the body, a so-called abscopal effect. And some of that, it was hypothesized, was because you were releasing some of the antigens and things with the cell death from the radiotherapy in the area where you were giving radiotherapy, and that then triggered off the patient's immune system. And so what this clinical trial is leveraging is that same process whereby you give some radiotherapy, so just 5 days of radiotherapy to whichever sites of lymphoma or diffuse large B-cell lymphoma that you want to, and then you're adding in that antibody to try and stimulate the patient's immune system to be able to then be more energized to be able to control the lymphoma. And unfortunately, I don't have any results to present from this clinical trial because it's only recently opened up at a few sites again in Victoria. But really, it's certainly quite a novel approach to be able to try and improve the patient's response to immune boosting treatment. So they're all treatments that are pretty much off the shelf, with the exception of the CAR T-cell therapies, which is the only one of those type of approaches which is somewhat personalized to patients. So what about if there are specific factors that we can identify within a patient whereby we would say that this is highly likely to mean that you're going to respond to a particular type of treatment, or conversely mean that you're not going to respond to treatment, in which case we should be investing your time and effort elsewhere. So I'll just talk about a few targeted options here, because this is an area where there's always ongoing research, and so there's plenty of potential treatment targets that will be evolving over time. So one of those agents that we've heard about recently called is the EZH2 pathway. So EZH2 normally functions to support the cellular DNA to be able to either turn on the copying process or turn off the copying process. And what we find in some types of lymphoma, so particularly follicular lymphoma, less so in some types of diffuse large B-cell lymphoma, is that this protein called EZH2 is basically defective. And you can see down here that the process by going from a less mature B cell to a antibody producing plasma cell, the B cells are maturing through the lymph node, and they need this enzyme called EZH2 to assist in that process. But you want a bit of that to start with, and then it needs to be turned off so that basically the cell can then become a plasma cell that can produce antibodies. When you've got too much EZH2, then that actually stops the turning off of the cell, and that leads to the cell basically being unable to die off and unable to perform the final stages of maturation to lead to being able to produce antibodies. And so it's been recognized that this mutation is present that basically leads to the enzyme being activated all the time, and that essentially contributes to the development of some types of B-cell lymphomas. So it was thought if we identify that target, then what about if we can restore that balance by essentially turning that pathway off? And so this drug called tazemetostat was developed and has been put into clinical trials. So this was recruiting in Australia as well as around the many parts of the world, and specifically targeting the patients with follicular lymphoma. So about 20% of patients with follicular lymphoma have got this EZH2 mutation. And so this study was trying to assess the benefit in patients who had the mutation compared to the standard type of EZH2. So this is the clinical trial, and in patients who had the EZH2 mutation, the vast majority of these patients responded. So over 80% of patients responded, and even in patients who didn't kind of drift below the magical 50% reduction in lymph node size and things, they were still getting clinical benefit from the drug, and it was really given without any clinically significant toxicity in this follicular lymphoma study. So certainly worthwhile pursuing further, and I know ongoing trials are planned for tazemetostat. So another type of pretty uncommon type of indolent lymphoma called hairy cell leukemia, and this is just a picture down the microscope of these leukemic cells. So hairy cells called such because they have these fine cytoplasmic projections around the cytoplasm of the lymphoma cells, and it was known that there are particular abnormalities in these signaling pathways. So similar to where the PI3 kinases and ibrutinib was fitting in with the B cell receptor pathway, it was noted that patients with hairy cell leukemia had the vast majority of patients had this abnormality in BRAF, which triggered off this signaling pathway. And so then BRAF inhibitor was developed, and this has certainly got some background in some types of solid malignancies where BRAF is abnormal in those types of cancers. And so this antibody was given, and this was really groundbreaking, even though it was a very small clinical trial, only 25 patients. You can see that for patients who didn't have many treatment options available, actually, they actually had a fantastic response to this vemurafenib, and that's really shows that if you've got a specific mutation that's present in a particular type of lymphoma, and you've got a drug that can target that particular mutation, that it seems to work very well for many of these patients. So Waldenstrom's macroglobulinemia, or lymphoplasmacytic lymphoma, this is a bit more complex than just a single genetic abnormality, and kind of speaks to the way that we approach treating these patients. So standard therapy for patients with lymphoplasmacytic lymphoma would be a combination of antibody therapy, so something on the cell surface, and more recently some patients would be getting some bortezomib, which targets NF-kappa B, but we can also target this whole process with a drug called ibrutinib, which targets the B cell receptor, or BTK, and through some elegant experiments, it was noted that patients with Waldenstrom's have the majority of patients have abnormalities in MyD88, and this was the basis by which we were able to differentiate some of the behaviour of patients with Waldenstrom's. So this is a clinical trial where ibrutinib was administered to patients with Waldenstrom's, and it was either ibrutinib and rituximab or rituximab alone, and you can see that ibrutinib worked a bit better than just the rituximab on its own. But it's not the same story amongst all of the different mutations. So some of these patients had abnormalities in MyD88, so about 70 to 80% of patients had MyD88 abnormalities, and they seem to perform better. So this is the patients who got ibrutinib, are in the solid lines up the top. The patients who had the MyD88 mutations alone are in green, and they seem to do a bit better. So that information basically tells us that in patients where we'd be thinking about ibrutinib-based therapy, that we should probably be checking their MyD88 status, because it seems to make sense that if you've got the mutation, then you're likely to respond better to ibrutinib compared to patients who don't have the mutation. So I intentionally left it with some time to answer questions and things at the end. But what I've hoped to show is really through using follicular lymphoma as the kind of archetype for how indolent lymphomas are treated these days, that there's many and varied treatment options, and not everyone these days is going to need aggressive chemotherapy or stem cell transplants or continuous therapy. Many patients will actually need fairly minimal therapy, if any at all. But certainly in those patients where the lymphoma is recurring, then that's where we need to be investing most of our time and effort in terms of finding the best treatments for an individual patient. And certainly there's lots of promising small molecules that are coming along, and I think that they'll probably be combined in the future with our standard chemotherapy approaches. But what we've seen certainly in large cell lymphoma is that just adding additional drugs to standard chemotherapy sometimes increases the side effects and doesn't help that much in terms of controlling the lymphoma. But we're certainly getting smarter about understanding what things go well together, and when we need to be backing off treatments and just giving targeted treatments on their own. And certainly as we understand more about the mutational status of different lymphomas, and more testing of that is easily available, then hopefully we'll be able to use that information to be able to pick the best treatments for patients going down the track. And I'm happy to stop there and to take any further questions.
Oh, that's wonderful. Thank you so much, Michael. It's a really great overview of a very big topic. So thank you for covering all that. And it's a very exciting time because there is so many new treatments out there, and it's such a confusing time for patients to work out what is suitable for them and what, because it's such an individual thing between patients. So yeah, thank you. We've got lots of great questions throughout, but I guess a couple of main comments were, do you see that treatment might become chemo-free? I know you chemo-free completely. I know you touched on there's side effects still with these novel therapies, but can you see this happening?
Yes, I think that for some patients that may well be possible. Now, I've certainly treated a few patients on the upfront follicular lymphoma studies, and yep, certainly a few of my patients have got quite significant side effects from the checkpoint inhibitors. So even though it's chemo-free, it's certainly not side effect-free, and I think really trying to find the best patients that are going to benefit from that approach is what these clinical trials are aiming to do. So most of these trials have got lots of biological sub-studies built into them, where we're trying to identify exactly which factors will be important in terms of picking these treatments for patients down the track. Having said that, the standard treatment these days, so for patients with follicular lymphoma, for instance, that are getting obinutuzumab and CHOP, probably about 2/3 of these patients will not need treatment within 10 years. So even though they're getting 6 months of chemotherapy with obinutuzumab and a couple of years of maintenance of obinutuzumab, they're not having anything for another 10 years, which is actually a pretty good outcome. So if picking those patients where things are clearly needing longer term treatment is what I would love to have the tools to do, but in reality I don't think that that's going to come to fruition any amazingly soon, and so what we'll probably be left with is treating patients along the standard pathway to start with, and then when the lymphoma is coming back, really targeting our treatment in those patients based on mutation status and things.
Wonderful. And I guess that sort of touched on with like obinutuzumab being a new treatment for a lot of follicular and other subtypes as well. There's concerns from a couple of people here with the increased incidence of infection using obinutuzumab over using rituximab. And you've been touched on them, obviously, it's a deeper progression-free survival with that, but have you had experience with more infections?
Yeah, so I treated about 30 patients on the the gallium study. So that was obinutuzumab versus rituximab. And I would definitely say that some of our obinutuzumab patients had pretty nasty infections during maintenance, and that's made me a bit wary about that. But I think we've got a bit smarter since when that study was identified. So when that study was initially generated, was that we weren't routinely giving prophylaxis to try and prevent infections and things, whereas nowadays that's really become mandatory when we're giving these small molecule inhibitors and potent antibodies to be able to treat these lymphomas. And idelalisib, for instance, is the same. We weren't routinely giving prophylaxis, whereas now we definitely are. And I would say that the infections are probably a bit less, and we're a bit more aware of them and acting sooner rather than later, and controlling them that way. So I do think infections is still a bit of an issue, but we just need to be aware of it and moving quicker to control them.
Fantastic. A couple of questions about CLL. I mean, you touched on that a little bit, but with the second line treatments for CLL, I know some changes in the first line treatment, and that you're looking at being chemo free. Are you looking at maybe having venetoclax as a first line treatment in the future in a combination, do you think?
Yeah, so venetoclax in CLL was examined recently in the German Hodgkin, sorry, not German Hodgkin's, German CLL study group, and a number of Australian sites were part of that. So they took chlorambucil and obinutuzumab and compared that to venetoclax and obinutuzumab, and that's trial was published last year and showed that the venetoclax obinutuzumab group did better in terms of progression-free survival, and so on that basis, I'm sure that the Abbott will look to try and get that registered for use.
Great. You may or may not know the answer to this, with the incoming CAR T starting to more for the aggressive lymphomas, I guess, at the moment, but in Australia, and there's some trials with the more indolent lymphomas. Do you see a place still for allogeneic stem cell transplants in the future?
That's a hard question. So I think when we're considering transplant, it always comes down to lots of things: the condition of the patient, the type of donor, and donor availability. But I do think that probably the toxicity from and side effects from CAR T cell therapy is a bit more predictable than what we would see in allogeneic transplant. And so I would say yes, I think we'll see more CAR T cell therapy use compared to allogeneic transplants for patients.
Great. I have a question of a patient who's got marginal zone lymphoma. Do you recommend usually with your patients having maintenance rituximab?
So maintenance, the literature on maintenance for marginal zone lymphoma is obviously less compared to follicular lymphoma. So for instance, the gallium study, even though it wasn't randomized for maintenance or no maintenance, did include about 150 marginal zone lymphoma patients. So I think we can fairly safely extrapolate from what was found in follicular lymphoma to marginal zone lymphoma. So yes, for most patients with marginal zone lymphoma, if I've treated them with chemotherapy, I generally move on towards maintenance therapy.
Okay, great. There's a couple of COVID questions. So I guess it's a blanket for probably all patients who either have completed treatment even a couple of years ago, are currently receiving even maintenance therapy. How susceptible are they to COVID-19 and their immune systems, and how immunocompromised are they?
Yeah, so that really does depend on where they are in terms of their treatment. The first thing to say is that Australia is so lucky to have be in the position where we're in at the moment. I think probably a couple of months ago, most of us were really worried about how this was going to pan out. But now that the incidence is so low, really from a practical point of view, it's pretty much business as usual in terms of us picking treatments and things for patients. So I think that should give patients reasonable confidence that yes, there's COVID around, and that hopefully the overall numbers are low, that patients aren't going to get infected. But certainly someone who was actively receiving chemotherapy would be at a bit more risk, we would think, to develop severe COVID infection. There's been a little bit of literature coming out from various places around the world trying to report on small numbers of heme patients with COVID, and the data's only been on really small numbers. So it looks to be pretty nasty in patients who get it if they're receiving chemotherapy as an inpatient. There was a small study from China that reported the outcomes in that patient cohort, and that was pretty nasty. But then conversely, other types of therapies may actually improve a patient's chances of not getting severe COVID infection if they were to get infected. For instance, ibrutinib, there's been thoughts about trying to use that to kind of dampen down the patient's immune system, because in COVID, one of the problems with severe COVID is that the patient's immune system is too overactive, and basically white cells clog up the lungs, and so ibrutinib can potentially ameliorate that. So that's actually being tried as a therapeutic agent to treat patients with severe COVID. So I think it's quite grey in terms of the individual treatment's effect on developing severe COVID, but the good news is that there's so much less risk in Australia at the moment compared to other places in the world.
Yeah, I agree that we're very, very lucky at this stage. And just, I think we've got time for one more question, which is a pretty good one actually. Can or should follicular lymphoma patients be checked for EZH2 mutation, and would this help treatment choices?
Yeah, so that's a good question, and the answer is a bit around if you can get access to a drug that can target it, then yes, it makes sense to check for that. So at the moment, tazemetostat is not available on any newly recruiting clinical trials at the moment in Australia, but obviously if that were to change with new clinical trials opening up, then it would make sense to pre-screen a patient. Likewise, if tazemetostat eventually was able to get TGA registered and then PBS reimbursed, then I would imagine that you would have to screen and check that a patient definitely had that mutation to justify giving the tazemetostat.
Great. Sorry, there was just one more from the same similar sort of lines. The role and outlook of gene diagnosis and gene therapy. UDX Hiragata Clinic in Tokyo claims 60 to 80 successes in several types of lymphomas. Have you heard about this or have any?
I'm not familiar with that specific approach to treatment.
Maybe we'll find out that answer for you.
Yeah.
And we'll get back to you. Great. Oh, thank you so much, Michael, for your time and agreeing to do this for you. I think you've covered so many topics and questions throughout the presentation, and there's so many more questions there too, some wonderful questions, but I can try and get back to you, everyone, and answer those. I can answer those ones. Just putting up this one. Sorry, this is when it comes to technology and my fun. Okay, I'm just going to share this last slide just to sort of remind people about this. Oh, there we go. Oh, I'll close that. So just to remind everybody that to look at the fact sheets on our website. They do have a lot of these subtypes we discussed today, and on them there's actually a list of a lot of the medications that are currently being investigated around the world. So this will give you an opportunity to have that list and check out those medications, and looking at the clinical trials fact sheet to show how you can look at up what clinical trials are available, not only around the world, but also internationally too, and what might be coming our way. Also, we've just launched a lot of videos, as I mentioned earlier, so please jump on, and there's a lot of interviews from the American Haematology Society meeting, the big meeting in US just before we all got locked down. That has a lot of experts talking about all these trials and some of the ones that Michael mentioned today. And we have got a lot of other little short videos, which you can see a couple of snaps up on the screen at the moment, of doctors from around Australia with different topics about lymphoma too, and we'll be adding to those over time once we can get out and about a little bit more. So thank you so much again, Michael. That was a wonderful presentation, and again, this will be recorded and be uploaded very shortly. And thank you everyone for your time. Thank you.
Thank you.